Welcome to Raaonline. Today's class is about MCQ discussion. We will be discussing about MCQs on the topic Polycystic Ovarian Syndrome. So we have around 30 MCQs discussion where we'll deal about the pathophysiology, the etiology, the prevalence as well as about the treatment of Polycystic Ovarian Syndrome. So let's discuss the first MCQ over here. While evaluating a case of secondary amenorrhea in a 20-year-old woman, so it's a case of secondary amenorrhea, which means that she has attained puberty normally and now she's presenting you with secondary amenorrhea and the prolactin levels was elevated. So the prolactin level is around 77 nanograms per ml. So the normal prolactin level will be about less than 25 in the range of 4 to 25 nanograms per ml. So this is considered to be elevation of the prolactin levels. So prolactin is elevated and ultrasound done has found to be normal. So USG has been done and it is normal and there is no PCO morphology here. So in case of PCOD, sometimes they might have increased prolactin levels. So this proves that the PCO morphology has been ruled out. But as such, only PCO morphology alone is not going to diagnose PCOS also. It's a spectrum of disorder. But anyways, ultrasound has proved to be normal. The next thing is that she is not having any signs of hirsutism. So there's no signs of hirsutism means we assume their androgen levels to be normal. Because sometimes some patients, irrespective of the increased androgen levels, they might be asymptomatic, but majority of the cases, if there's no signs of hirsutism, if there's no acne or facial hair growth or any androgenic alopecia, if these signs of hirsutism is not present, we basically assume that woman to be stable and her androgen levels are within normal. So there's no signs of hirsutism, and so now they are asking you which of the following conditions could cause increased circulating prolactin levels. So what might be the most close? So whenever it comes to any disorders where the values are increased, we can give only DDs. So out of these 5, so we are going to choose the best one. So the first thing is hyperthyroidism. So when you talk about hyperthyroidism, so usually what happens in hyperthyroidism, the thyroid hormone levels are high. As a result, the TSH is going to be low because of the negative feedback mechanism, and also the thyroid releasing hormone is going to be low. So always keep in mind whenever the thyroid releasing hormone is high, in case of hypothyroidism, so when the thyroid hormones are low, the thyroid releasing hormone is high, that will also stimulate the increased production of prolactin. So in this case, obviously the prolactin level is going to be low only, it is not going to be high. But in case of a hypothyroidism, what happens? In case of hypothyroidism, the hormone levels are low, so the TSH will be high and also the thyroid releasing hormone will also be high, and that acts as a stimulant factor. So this will act as a stimulant factor for the production of increased prolactin. So this will increase the prolactin. So only in hypothyroidism you have increased prolactin levels, and in hyperthyroidism you will not see increased prolactin levels. So this effectively rules out the first option. So now stress. So stress is found to be the right answer here. So what happens in stress is that stress is also causes a physiological rise. A mild elevation in prolactin has been noted in case of stress. What does stress do? Whenever stress happens, there is decrease in dopamine. So usually dopamine is a negative feedback regulator of prolactin. So whenever dopamine is high, prolactin is going to be low. So because of acute conditions where the patient is under stress, in that case what happens? The dopamine levels will go low and obviously the prolactin will be high. So this simply explains the patient is totally normal. She might have had an acute episode of stress following which the prolactin levels would be elevated. So this comes close to our diagnosis. Because of the prolactin, she's having secondary amenorrhea, but her ultrasound is normal. There's no signs of hirsutism also. So this closely correlates with that of stress. But let's rule out the other options also. So what happens in anorexia nervosa, PCOS and adrenal hyperplasia? So we'll rule out one by one. So in anorexia nervosa, so in this condition, what happens is that the GnRH, it's like an hypothalamic amenorrhea. So the GnRH pulsatile secretion goes low. As a result, they will have menstrual disturbances also. So they will have amenorrhea also, and hypothalamic amenorrhea will be present, but the prolactin levels is usually normal here. So this is regarding anorexia nervosa. The next option was adrenal hyperplasia. So what happens in adrenal hyperplasia? There is increased production of androgens, but the prolactin levels is normal. So because of the increased production of androgens, obviously the patient should have presented with hirsutism features, which is not seen. And in adrenal hyperplasia, usually the prolactin level is normal. So the next thing is PCOS. So PCOS is a complex spectrum, but here what I want to say is that if PCOS is there, some morphology, either an ultrasound or she might also have certain features of hirsutism. So since these two criteria has been ruled out, PCOS will not be a correct diagnosis to choose here. If the same question changes and if the patient presents you with hirsutism, if she is having androgen alopecia, if she is having acne, if she is having facial hair growth, all those features of hirsutism when you see, if the question has been changed to signs of hirsutism, if it is plus, then my answer will move towards PCOD. But here it's a straight cut answer because there's no signs of hirsutism, USG is normal, so PCOS more or less is ruled out. And this episode of amenorrhea may be because of the stress. So the stress will be the right answer in this question.